I'm Marston Linehan. I'm the Chief of Surgery at the National Institutes of Health. I'm very happy to be here at the RSM talking about our experience over the past 34 years with kidney cancer. When we started working on kidney cancer in the early 1980s, we thought of kidney cancer as a single disease. We now know that kidney cancer is not a single disease. It's made up of a number of different types of cancer that just happen to occur in the kidney. They have different histologies. The patients undergo different clinical course, different response to therapy, and as we have learned, they're caused by different genes. We now know that at least 16 genes cause kidney cancer, and we've been working to understand how each of these cancer gene pathways worked. We started initially in the early 80s looking at clear cell kidney cancer, and to identify the gene for clear cell kidney cancer, we studied families with the hereditary cancer syndrome von Hippel-Lindau, or VHL. VHL is a hereditary cancer syndrome in which affected individuals are at risk to develop tumors in a number of organs, including, of course, the kidney, where they're at risk to develop bilateral, multifocal, clear cell kidney cancer. We've developed a therapeutic approach managing patients with VHL-associated kidney cancer, where we do active surveillance until the largest tumor reaches 3 centimeters, at which time we recommend surgical intervention. And over the past 28 years, we've not had a single patient yet develop metastatic disease when managed in this fashion. So to identify the gene for von Hippel-Lindau, we studied families, and this is with my colleague and dear friend Burton Zabar and Michael Lerman, and we searched for the genes along with Eamon Maher, who's here in the UK, and we identified the location for the gene on chromosome 3. Then in the spring of 1993, we identified the VHL gene on chromosome 3 as a 3-exon gene. And so we looked for mutations in VHL in the families, and we've now found mutations of the VHL gene in every single family. We've seen nearly 400 families with VHL. And then a year later, we showed that the VHL gene is also the gene that we find mutated in 90% of tumors from patients with clear cell kidney cancer. So VHL is the gene for the hereditary form of clear cell renal cancer in von Hippel-Lindau syndrome, and it's also the gene for the common form of clear cell kidney cancer. Now, over the years, we and others have studied the VHL gene pathway, and we know now that the VHL protein, the product of the VHL gene, targets the hypoxia-inducible factors, particularly HIF-2, for degradation. And understanding this pathway has now led the US FDA, the Food and Drug Administration, to approve 9 therapies for clear cell kidney cancer targeting the VHL gene. And we're very, very, very touched about that, and we're very happy about that, to see these dramatic responses and to be seeing these patients with improved survival. However, we're not home yet. In other words, we still have a ways to go. We're not curing most of these patients. So we and others are looking at other ways to target the pathway. We're very excited about new approaches targeting the HIF-2 pathway in particular, and we will see. We're getting ready to start a trial with a drug targeting the HIF-2 pathway in our patients with VHL, and we and others currently are looking at that in patients with clear cell kidney cancer, and we're very hopeful about that. Now, not too long after that, we started studying other families in which we found hereditary papillary renal carcinoma. This is an autosomal dominant hereditary cancer syndrome in which affected patients are at risk to develop bilateral, multifocal type 1 papillary kidney cancer. And again, by working with our colleagues, Burton Zabar, we did genetic linkage analysis, and identified the MET gene as the gene for HPRC. So we now have run clinical trial targeting the MET gene pathway in HPRC patients and seen very dramatic responses. So we say to ourselves, are we home yet? We say, no, not yet. We need to do better, but we have seen dramatic responses, and we think this is proof of principle that targeting a kidney cancer gene pathway can lead to tumor regression in the tumors in patients with cancer, and we're hopeful to expanding that not only in this type of kidney cancer, but to others as well. And then not too long after that, we started seeing families who had a type of kidney cancer we hadn't seen before, and these patients had sort of skin bumps, you might say. They were actually turned out to be what are called fibrofolliculomas. And fibrofolliculomas, that cutaneous fibrofolliculomas, those are little hair follicle tumors that run in families, had been described before by three individuals from Canada, Burt, Hogg, and Dubé, and that is, of course, the BHD syndrome. And we showed that kidney cancer can run in BHD families. And so we now have run a genetic study to find the BHD gene, which we located. This one was on chromosome 17. We reported this in 2002. We called this the folliculin or FLCN gene. And we find mutations in FLCN and folliculin in 98% of our BHD patients. So we manage these patients, which are at risk to develop chromophobe kidney cancer, hybrid oncocytic kidney cancer, clear cell kidney cancer, and oncocytoma, to manage those patients, the BHD kidney cancer patients, again with active surveillance. We watch these tumors till the largest tumor reaches 3 centimeters, at which time we recommend surgical intervention. So we also, about that time in the late 80s, started seeing patients with another type of papillary kidney cancer. We thought all hereditary papillary kidney cancer was the same. It turns out it wasn't. And this type, papillary kidney cancer, we initially described as hereditary papillary renal carcinoma. We were thinking hereditary papillary renal carcinoma type 2. However, it was then redescribed and renamed and now goes by hereditary leiomyomatosis and renal cell cancer, or HLRCC. And patients with HLRCC are at risk to develop an inherited form of cutaneous lesions, cutaneous leiomyomas they're called, which can be on the trunk or on the arms or sometimes on the face. It can be very painful. But these patients, the women in these families who are affected, also develop uterine leiomyomas. Some people call them fibroids. And the tip-off for those of us who are clinicians is that they are early onset. So in our initial report, 50% of our women, of the females in the families who were affected, had had hysterectomies in their 20s. So this is a real phenotype, a difficult phenotype for women. Of course, now we recommend myomectomies in those patients, but if you have a family with type 2 papillary kidney cancer and early fibroids, please think about HLRCC. And the kidney cancer that these patients are at risk for is a very aggressive type of type 2 papillary kidney cancer. This can be early onset. We've seen this cancer in teenagers. We've seen it in a 10-year-old, and we've seen it in the first tumor in a 77-year-old. So these patients, we recommend have annual surveillance. We recommend MRI starting at 8 years of age. And our experience since 1992 is that you detect these tumors, you get them out when they're small, the patients do fine. The patients that cause us all trouble, of course, are the ones who present with advanced disease. So we recommend annual imaging, and we think that, well, we know that's very important in these families. Now, these patients can get solid tumors in their kidneys, They can get cysts in their kidneys, which are benign, but they can also get cysts which have tumors inside the cyst. So what we recommend for any patient who is affected with HLRCC, if a lesion is detected in the kidney, we do not recommend active surveillance. We recommend surgical intervention. And we do not do robotic surgery on these patients. Most of our patients with VHL or HPRC or BHD, we manage with robotic partial nephrectomy. HLRCC, we do not recommend robotic surgery on. We do all of our patients open. These patients are at risk to develop bilateral and multifocal tumors. They can be small, they can be hard to detect with imaging, and we recommend very detailed intraoperative ultrasound evaluation of each of these patients, and we also recommend wide margins on these. We have seen many patients who have developed HLRCC type 2 papillary kidney cancer, and it's very infiltrative into the normal renal parenchyma. The problem is we can't see that invasion into the parenchyma with imaging. It's not like clear cell kidney cancer. It's very different. We can't see it grossly when we're there. So we recommend wide surgical resection. We like to do partial nephrectomies, and we'd rather not do a nephrectomy because these patients have lifelong risks for multiple tumors in both kidneys. So we want to preserve the kidneys whenever we can. So we think this is very important in the management of these patients, and we can't stress enough how critically important it is to do annual imaging. So our experience is that kidney cancer is not a single disease. It's made up of a number of different types of cancers, different histologies, different clinical course, responding differently to therapy, and of course is caused by different genes. And it's our feeling that the clinician who manages these patients, that it's very important for us to understand the genetic basis of this disease that will change what we recommend as far as when to operate on these patients. It changes our operation with a VHL deficient clear cell kidney cancer, whether it be sporadic or whether it be hereditary. We would recommend enucleation of those tumors. If, for example, it's an HLRCC type 2 papillary kidney cancer, we recommend wide surgical resection. And also, we feel that understanding the pathways of the kidney cancer genes will help provide the foundation for the development of even more effective forms of therapy, we hope, for all patients with kidney cancer.